Usual place. I'm at my son's house in Maryland. I'm taking care of his diabetic ancient cat. Anyway, it's been quite a struggle. I'm- I was a lab tech, so I'm used to sticking people, but not so much cats. You have to stick them in the ear. Get a micro drop, and that's how you test their glucose. They're easy to give shots to. They complain a lot less than humans do. But let's go ahead and get started. Today we're going to tackle Chapter 13 and Chapter 16. Chapter 16 is just kind of a general chapter that covers what kind of jobs you can get and the interaction between psychology and law enforcement. So let's go ahead and get started. Chapter 13 deals with neurodevelopmental and disruptive disorders. This has to do with kids, so let's go ahead and get started. In the DSM-4, these conditions were considered within a larger category, disorders of infancy, childhood, or adolescence. However, the DSM-5 revision moved several of these disorders to other areas. Two new classifications: neurodevelopmental disorders spanning childhood and adolescence, disruptive impulse control and conduct disorders created by merging the impulse control dysfunctions with the disruptive conditions of childhood. Neurodevelopmental disorders include intellectual disability, specific learning disorders, motor disorders, communication disorders, autism spectrum disorders, attention deficit hyperactivity disorder. Disruptive impulse control and conduct disorders, oppositional defiant disorder, ODD, conduct disorders, CD, intermediate explosive disorder, which is kind of new, kleptomania, and pyromania. Neurodevelopmental disorders onset is during the period of biological development before the brain and nervous system are complete. Uh, that takes place sometime between the ages of 20 and 30, usually around 25. Yet they are quite varied in their symptoms, etiologies, and treatments. Boys are much more at risk than girls in several of these categories, and one reason may have something to do with the Y chromosome, which is much smaller than the X chromosome. So if there's a problem on the X chromosome, the Y chromosome doesn't cancel it out. So we see a lot more disruptive problems with males and females. Rett syndrome was removed from the DSM-4, now viewed as a condition that can cause mental disorders rather than a mental disorder itself. Rett syndrome had to do with females not developing, and they had a hand thing going where they rubbed their hands together to the extent that they rubbed them raw. Intellectual disability is diagnosed when there is evidence that intellectual abilities are significantly below average. Important adaptive skills are also impaired. The IQ score must be among the lowest 2.5% of the population. That's somewhere in the range of 70 or less. Level of adaptive functioning is assessed across three domains: conceptual, which is academic, social, and of course practical. There must be adaptive dysfunction in at least one of these domains that results in failure to acquire normal milestones in personal independence and social responsibility, language and communication, academic abilities, independent care skills, money management, and social judgment. The deficit in adaptive function must be evident in multiple environments and require ongoing support by others. Deficits that require ongoing support must also be present in at least one area of adaptive daily functioning across multiple environments, and I have no idea why I put this picture in here. Fallout. Maybe that's it. Anyway, intellectual disability can be specified as mild, moderate, severe, or profound. DSM-4 was determined by IQ scores. The DSM-5 defined in terms of the degree of adaptive impairment. Okay, so we don't talk about IQ scores anymore. The incidence of intellectual disorder may be 1% of the population, with males diagnosed more often than females. Individuals with IQs less than
New
65,
messages received from Chris.
that's my son. Individuals with IQs less than 65, two standard deviations below the mean, who show significant impairment in adaptive functioning, meet the criteria for intellectual disability.
New messages received from Chris.
Okay. Individuals who score between 70 and 85 may meet the definition for borderline intellectual functioning. And there you go. That's the way it works. So we have the same number of people below 70 as we have above 130. So for every genius, we have an individual with an intellectual disability. The majority, perhaps 85% of those with intellectual disability have a mild intellectual disability. Their subnormal intelligence becomes apparent during the school years, and they tend to fall behind in their age group. With persistence, they can learn academic skills roughly comparable to the sixth grade level by their late teens. With extended education and assistance, independence in several areas can be achieved, but ongoing support is needed. Moderate intellectual disability, about 10% of the people with intellectual disability have moderate intellectual disability. They usually learn to talk during the preschool years, but later and more slowly than others. They're likely to show impairments in sensory motor development. Their academic abilities are markedly low, and their social skills are likely to be limited. As adults, they can contribute to their own support in protective environments. Severe intellectual disability, about 3.5% of those with intellectual disability have a severe intellectual disability. Impaired development is apparent in infancy or early childhood in the form of poor motor development, minimal speech, and often the presence of physical deformities. Many can learn to talk in simple words and phrases and learn elementary health and grooming habits. As adults, they may learn to perform certain routine tasks, but generally require complete supervision and economic support. The smallest group of those with intellectual disability, about 1.5%, have a profound intellectual disability. Extreme deficits in both intellectual and sensory motor functions are apparent early in life. Many have severe physical deformities. Usually, total care is required for the rest of their lives. Biological influences that may cause intellectual disability, heredity, of course, alterations of embryological development, pregnancy or perinatal problems, acquired medical conditions. The alterations of embryological development usually has to do with the toxic substances, teratogens is what we refer to them, but drugs very frequently are the cause of the alterations of embryological development. Environmental influences, growing up in an environment with little stimulation, alcohol, heroin, crystal meth, even marijuana can cause problems. Nicotine has caused problems that we have been able to detect. Um, for a while, they were saying that caffeine might cause problems, but now there has been no proof of that. But most of the really toxic drugs, including pharmaceuticals, and this is one of the reasons why during pregnancy, a woman is, and her physician, and her pediatrician, and her gynecologist are monitoring what drugs she is taking. Environmental influences, growing up in an environment with little stimulation. No specific causal factors are identified in about 30 to 40% of the cases of intellectual disability. PKU is an inherited inability to metabolize phenylalanine. The genetic site is located on chromosome 12. Low phenylalanine diet throughout childhood and adolescence prevents the development of intellectual disability. One of the things that we do as soon as the baby is born, after they take their first meal of one form or another, usually it's milk. mother's milk, hopefully. Well, that's just one way to do it, but usually it's milk. After their first meal, we draw their blood about 3 or 4 hours later, and we determine whether there is any phenylketonuria. Urea is a waste product. Phenylketonuria is a waste product of phenylalanine metabolism. And that's one of the things that lab techs do. They check for PKU, this waste product, because this waste product will build up in the brain and destroy brain cells, and that's why they have the intellectual disability. Fragile X syndrome is where there is a nearly separated segment of the long arm of the X chromosome. Fragile X syndrome is due to a mutation on the FMR1 gene site. Fragile X syndrome is the most common heritable condition associated with intellectual disability. It was PKU before the 1950s. It was PKU that caused all the intellectual disability. Since we didn't have a way of testing it, that was a problem. Then we developed a test for PKU, and now it's Fragile X that we see more frequently than anything else. PKU, because we draw the baby's blood right after the baby is born and has its first meal, we are able to detect the abundance of PKU in their system, and we can put them on a diet immediately. But Fragile X, of course, there's nothing we can do about that one. Fragile X syndrome is the most common heritable condition associated with intellectual disability. Fragile X syndrome can be detected through blood tests or prenatally through amniocentesis, but there's not much we can do with it. Males are disproportionately affected by this condition because they carry only one X chromosome, and if that X chromosome has a break, it's fragile, then there's nothing we can do. It can't be canceled out by the other X chromosome. Galactosemia, maple syrup, urinary disease, identifiable prenatally through amniocentesis. It really does smell like maple syrup. One time I went into the nursery, the newborn nursery, and I was drawing blood from a baby, and I said, somebody's eating pancakes. And of course, the nurses don't eat in the nursery, but I smelled pancakes. What I thought I was smelling was maple syrup. Anyway, so I'd asked the nurse, is somebody eating pancakes? I smell pancakes. And of course, they got all pissed. They got real upset that I was accusing them of something. And eventually what happened was somebody else came in and said exactly the same thing. They wrote me up. They said that I was accusing them of something that didn't happen, and then it turned out, because they had been in there, the whole time, they were used to the smell. They didn't even smell the urine that smelled like maple syrup. Normally, of course, when you're in a newborn nursery with all that urine and feces around, you stop smelling things. But of course, as a lab tech that just happened to come in to draw somebody's blood, probably a PKU, I was primed to smell whatever was in there, and what I smelled was maple syrup. So eventually, of course, they found the baby with the galactosemia. It's not that common a disease or a condition. It's not really a disease. It's a condition. Anyway, so they saved the baby's life by smelling pancakes. Tay-Sachs disease is identifiable prenatally through amniocentesis. We can tell both of these through amniocentesis. Usually, women do not get amniocenteses. Older women, women in their over 30, may get an amniocentesis, but usually younger women don't get amniocentesis. Tuberous sclerosis epiloia is the most widely known dominant inherited condition. It's caused by tuberous calcifications in the brain. It produces intellectual disability and epilepsy. And this is what you see. Tuberous sclerosis. Down syndrome is associated with intellectual impairment as well as a wide variety of physical anomalies. Down syndrome occurs once in about every 700 births, and the risk is strongly linked to maternal age. So the older the ova, the more likely that the child will have Down syndrome. The incidence increases from 1 to 2,000 births for 20-year-old mothers to 1 in 25 for mothers older than 45 years old. My daughter was 43 when she gave birth to my grandson. We were both scared throughout her pregnancy, since she's a biologist and I had worked in the laboratory. We both knew the dangers of what was going on. So once she got past the 22nd week, she had an amniocentesis. Everything was fine. My grandson was born, perfect as far as that goes. Now he's 13. He's not nearly as perfect as he used to be. Anyway, but 1 in 25, that's a lot. That's not really very good odds. The leading cause of preventable intellectual disability is the effect of maternal alcohol consumption on the developing embryo. Now, my daughter was really, really careful not to consume not only alcohol, but she wouldn't even consume caffeine. She was very, very careful about what she put into her body. Really proud of her. She did such a wonderful job. Fetal alcohol syndrome produces characteristic biological and psychological impairments, including mild to moderate intellectual disability. The behavioral ramifications of FAS would be diagnosed as neurodevelopmental disorder associated with prenatal alcohol exposure. Harmful biological influences that have been either directly or indirectly associated with intellectual disability: poor maternal health, including acute and chronic maternal infections, maternal fetal blood incompatibility, that's Rh disease. My own children, my wife was Rh negative and I'm Rh positive, so there was a possibility of a problem, but she got RhoGAM, and that took care of that. Anoxia, that's not enough oxygen as the baby is being born. Radiation, if the mother gets an x-ray or is exposed to radiation. Drugs, of course, as we talked before. And prematurity if the baby's born before the 38th week. Common prenatal infections associated with intellectual disability: rubella, toxoplasmosis, syphilis, and cytomegalovirus. This is toxoplasmosis. That's why women should not clean out litter boxes, because of toxoplasmosis. Cytomegalovirus is the virus that causes warts. And so there you go. So she needs to stay away from the measles. She needs to leave the cat alone. She needs to make sure her husband or whoever she's having sex with is clean, and she needs to stay away from warts. Preterm delivery usually have low birth weights. Premature infants have greater health risks in many areas and are at an increased risk for intellectual disability and other developmental disorders. Medical interventions have significantly improved the survival ability of premature infants, but they remain at high risk for cognitive impairment, sensory impairment, and various conditions of the central nervous system. With this outbreak of measles that we have seen this year because of children not being vaccinated, this it can be deadly for school-age children, but it can also be deadly for unborn infants, because the measles virus is out there, and it can infect pregnant women. And so this is something nobody's talking about at this point, But down the line, in the next two or 3 years, this whole problem with not having your child vaccinated is going to probably be a little bit more serious because we see women that are having babies with that are infected with rubella, or she is infected with rubella, and we're seeing more intellectual disability due to that. And so, this stuff runs downhill. This is a problem, and of course, the unborn babies are, they are victims of not being vaccinated, of children not being vaccinated, and that's just tragic. Cretinism is stunted physical and mental development caused by impaired functioning of the thyroid gland, one cause of which is an iodine deficient diet. Intellectual disability, usually severe, is accompanied by certain characteristic physical features, including a stunted growth, dry skin, coarse hair, and a large head. And that is what cretinism is. Preventive efforts such as the wide availability of iodized salt have led to the virtual elimination of this condition in the Western world, and that W should be capitalized. Yeah, and that's one of the reasons why I always eat iodized salt. The closer you live to the more seafood that you eat, the more iodine you're getting in your diet. The closer to the seashore you are, the more iodine potentially you're getting in your diet. Those of us who live in the middle of the United States, we eat iodized salt because this was a really serious problem until goiter was caused by it. And cretinism was also a problem with the children in the middle of the country who never ate seafood, or their parents never ate seafood. The salt didn't have any iodine in it, and now we iodize our salt. So I always get iodized salt because I'm from Indiana, which is right smack dab in the middle of the country. And I live in Iowa now, which is right smack dab in the middle of the country. Several medical conditions can lead to intellectual disability: encephalitis and meningitis, head trauma, brain tumors, and epilepsy, shaken baby syndrome can cause intellectual disability, lead poisoning, and hydrocephalus. And hydrocephaly this is what it looks like, where the brain is enlarged because there is too much cerebrospinal fluid, and it causes what they refer to as waterhead. It's actually hydrocephaly, that's what it means, waterhead. Psychological and social factors can produce deficits in intelligence, extreme deprivation and isolation, inadequate intellectual stimulation, quality of parental interaction. IQ change in identical twin boys rescued at age 7 from abuse. After 6 years of environmental enrichment and therapy, their IQs rose to the normal range. And this is something that has been seen in the past. It is important to act to control as many of the conditions that cause intellectual disability as possible. Family planning should include consideration of maternal age. In other words, as a woman ages, maybe she shouldn't have a child. That's a possibility. Getting into your 40s is a little old. It's hard on the woman, and it certainly is more dangerous for the infant. But like I said, my daughter decided she hated kids up until she was like 40 years old. Then she decides to get pregnant. During pregnancy, the fetus must be properly nourished while exposure to alcohol or other toxins is eliminated. Maternal health should be monitored and infections should be avoided. After birth, an enriched and stimulating environment is important, both in school and at home. Enrichment programs target perceptual, motor, cognitive, language, and social emotional development. Early intervention programs have demonstrated their effectiveness in reducing the risk of cultural, familial, intellectual disability. Head Start is one such program, wonderful program. Head Start has led to the increase of IQs all over the United States. Special education programs within schools also do an amazing job of helping children with intellectual disability. For more serious cases, treatment occurs within residential living facilities, treatment facilities, or institutions to support such persons. Structured behavior modification is very useful in training important skills such as self care, language, daily living abilities, and prevention of self injury. A comprehensive review of behavioral interventions for self injury involving mostly persons with severe or profound intellectual disability found both reinforcement and punishment based techniques to be effective. There are no medications that treat intellectual disability, although there are a variety of antipsychotic, sedative, and tranquilizing drugs that can be used to control behavioral problems. Data on the effectiveness of various drug therapies at best only offer weak support. Nonetheless, use of medications to control challenging behavior in those with intellectual disability remains quite common. Specific learning disorders combines the DSM-4 diagnoses of reading disorder, mathematics disorder, disorder of written expression, and learning disorder not otherwise specified. Diagnosis requires difficulties in learning and academic skills involving reading, spelling, writing, or mathematics in which measured abilities are below what would be expected by the student's chronological age. Together, specific learning disorders may affect 5% to 15% of the population. The difficulties that lead to the diagnosis cannot be due to intellectual disability, and they must have persisted for 6 months or more in spite of attempts to remediate them. The diagnosis includes specifiers for areas of impairment, with impairment in reading, with impairment in written expression, with impairment in mathematics, severity, mild, moderate, or severe. Reading difficulties may involve errors in comprehension, slow reading, and oral substitutions, distortions, or omissions. The condition has also been called dyslexia. As many as 80% are males, although this may be biased as boys are more likely to show disruptive behavior along with reading dysfunction and thus attract diagnostic attention. And I have a brother and a sister with dyslexia. And according to my mother, my dad probably had dyslexia, but I don't know. They all function fairly well, so it's hard to tell. None of them were ever diagnosed with dyslexia. My sister is in her 70s and doesn't read at this point. She doesn't read anything. Won't read anything. So, and the problem seems to have been that she had a problem reading when she was in the first, second, and third grade. Mathematical difficulties can include the linguistic, perceptual, attentional, and computational skills involved in mathematic achievement. Disorder of written expression is characterized by deficient writing skills, often including combinations of poor handwriting, poor grammar and punctuation, common spelling errors, and poor organization of paragraphs or sentences. It can be associated with perceptual, motor, or language deficits. The DSM-5 defines specific learning disorder as having a biological origin causing a dysfunction in the brain without being more specific. Prematurity, low birth rate, and prenatal exposure to nicotine are listed as risk factors. Specific learning disorders, especially involving reading and math, tend to run in families. When learning disorders are comorbid with attention deficit hyperactivity disorder, ADHD, outcomes tend to be poor. Significant correlations between the specific learning disorders may suggest they interrelate at a more basic level. Symptoms may persist into adulthood for up to 4% of the population. Motor disorders are conditions in which a deficit in motor coordination or delay in meeting motor development milestones interferes with academic or daily life. These include developmental coordination disorders, stereotypic movement disorders, and tic disorders. Motor disorders involves a deficit in motor coordination or delay in meeting motor development milestones, interfering with academic or daily life. Motor disorders are diagnosed when clumsiness is not due to a physical disability such as cerebral palsy or muscular dystrophy, nor is it characteristic of the motor difficulties associated with intellectual disability. For diagnosis to qualify, motor deficiencies must be severe enough to interfere with the normal activities of daily living. DSM 5 reports that the prevalence between 5 to 6% and children aged 5 to 11 years. In some cases, it persists into adulthood. A stereotypic movement disorder, the key feature is a motor behavior that is non-functional and repetitive. Body rocking, hand waving or shaking, eye poking, head banging, face slapping, self biting. Risk factors may include social isolation or environmental stress. Some neurogenetic conditions, such as Rett syndrome, also contribute to stereotypic movement disorder. Prevalence may be between 10 to 15% of those with intellectual disability living in residential facilities. There is support for behavioral methods that provide aversive consequences contingent on self-injurious acts while simultaneously shaping competing responses. Case reports have indicated that the opiate receptor site blocker naltrexone has been useful for some individuals with self-injurious behavior. Tics are sudden stereotype motor movements or vocalizations that are rapid, recurrent, non-rhythmic, and experienced as irresistible. Simple motor tics, blinking, grimacing, etc. Complex motor tics, hand gestures, twirling, etc. Simple verbal tics, clearing the throat or grunting. Complex verbal tics, words or phrases. May include coprolalia, verbal obscenities, or socially unacceptable verbalizations. This is actually quite rare. It doesn't really happen that often, the coprolalia. It means speaking about poop. Copro means feces or poop. Potty mouth is what it means. The DSM-5 includes 4 disorders involving either verbal tics, motor tics, or a combination of the two. Tourette's disorder, persistent chronic motor tic disorder, persistent chronic vocal tic disorder, or provisional tic disorder. In Tourette's disorder, both multiple motor and vocal tics must have persisted for at least a year. Symptoms must have begun before the age of 18 years. Usually it begins by age 6 and can wax and wane in a course that tends to diminish in severity as the person ages. The tics, which happen many times each day, cannot be attributable to a general medical condition or a substance. In less than 10% of the persons, coprolalia occurs, and that's what I was saying, it's not all that common. Persons with Tourette's disorder often feel discomfort, shame, or social embarrassment over their condition. Impairment in functioning is not among the diagnostic criteria for this condition. About 1/2 of people with Tourette's disorder also have ADHD. Tourette's disorder also may occur with obsessive compulsive disorder. The stimulants used to treat ADHD have been associated with an increased tic incidence and severity in some studies. The diagnosis is given to men between 2 and 5 times more often than women. It is a rare condition, and upper prevalence estimate is about 8 school-age children per 1,000. There appears to be a substantial genetic component to the disorder. The recent randomized controlled trial found behavior therapy to be as effective as antipsychotic medications for treating Tourette's disorder in children. In other words, don't give them drugs. Just try to use behavior modification to try to get them to control the movement. Persistent motor or vocal tic disorder involves either multiple vocal or motor tics, but not both. Persistent motor or vocal tic disorder differs from Tourette's disorder, which requires the presence of both at some point. Like Tourette's disorder, symptoms must persist for a year and have onset before the age of 18. For DSM-5 classifications of communication disorders, language disorder, speech sound disorder, childhood onset fluency disorder, stuttering, social pragmatic communication disorder. All the communication disorders occur more commonly among males than females. These disorders also appear to be aggregate within families, although specific genetic, neurological, environmental causes are unknown. Language disorder involves language use and acquisition that is substantially below the level expected, shown by limited vocabulary, word recall difficulty, shortened or overly simplistic sentences, and errors in verbal tense, or a deficiency of understandable discourse. Receptive communication may also be affected, involving difficulties understanding words, sentences, or particular types of word phrases, such as if-then statements. Expression of written language, spoken language, and sign language can be impaired. Course is variable, although some difficulties tend to persist into adulthood. Those with the receptive language deficits appear to have a poor prognosis. Speech sound disorder is an articulation disorder in which persons fail to use the speech sounds that are normal for their developmental level. Difficulties may occur in knowledge of the correct phonological sounds or in the motor coordination required for speaking. Lisping is common. Speech therapy is helpful and articulation tends to improve over time. If language disorder is also present, the prognosis is less optimistic. Stuttering is a disturbance in speech fluency, typically characterized by speech blocks, repetitions of words or syllables, and prolongations of speech sounds. Difficulties increase under conditions of stress or anxiety. Approximately 1% of children are persistent stutterers, and another 4 to 5% show transitory stuttering when young but outgrow it in time. Childhood onset fluency disorder almost always starts before the age of 8, but can be coded for adult onset. Usually the onset is gradual. In families in which the father has a history of stuttering, 10% of daughters and 20% of sons also stutter. And of course, President Biden was a stutterer. But so is James Earl Jones. Darth Vader was a stutterer. And one of the ways that he controlled his stuttering was by speaking low. He had to do this in order to concentrate. It made him concentrate by speaking in a low voice, and that controlled his stuttering. So if you can get someone to change the pattern of their speech, a lot of times the stuttering will stop. One of the things that we know is that stutterers can sing without stuttering. Okay. Half or more of the individuals who begin to stutter will recover with little or no professional help. According to the DSM-5, 65% to 85% of stutterers recover from the dysfluency. Stutterers report substantial reduction in stuttering when engaged in a number of different activities. Reading in chorus, speaking to an animal or to an infant, singing, swearing, speaking to a rhythmic swing of the arm or foot tapping, or imitating a regional or foreign dialect will stop the stuttering. And that's one of the ways that James Earl Jones was able to control his stuttering. He's from the South, and he not only spoke with a low voice, but he also spoke with a northern voice because he was from the South, and he was African American. Delayed auditory feedback is a technique in which a stutterer's speech is played back through earphones with about a 1/10 of a second delay. The stuttering is almost completely suppressed. Regulated breathing during speech. Subjects practice speaking during natural exhalation. Improvement has significant and sustained for all children outside of the treatment setting. Social communication disorder is new to the DSM 5. Basic practical social communication skills such as greetings, taking turns in conversation, asking for clarifications, or matching speech styles to the context of the listener, such as playground versus classroom, are impaired. Social communication disorder is not due to intellectual deficiency, autism spectrum disorder, or other mental disorders, but does occur more commonly in families that have histories of autism, communication disorders, or learning disorders. In the DSM 5 the DSM 4's pervasive developmental disorders were combined into a single spectrum diagnosis. Autistic disorder, Asperger's disorder, childhood disintegrative disorder, and pervasive developmental disorder, not otherwise specified, are now combined into autism spectrum disorder. And people who were diagnosed with Asperger's syndrome are not happy about that. Autism spectrum disorder involves problems in social interactions, communication, or play. There is little social reciprocal interaction. In autism spectrum disorder, language is usually delayed or absent. When it is present, it often seems abnormal in pitch, tone, or rhythm. There are a narrow range of interests and activities. Stereotypic movement are often present. The severity of autism spectrum disorder is specified by the degree of deficits shown, indicated by requiring support, for example, difficulty initiating social interactions, requiring substantial support, marked deficits within the supports in place, frequent and obvious repetitive behaviors, requiring very substantial support, minimal response to social overtures, repetitive behaviors, markedly interfere with functioning. One of the individuals who has Asperger's syndrome, he calls himself an Aspie, is Elon Musk. And he claims that it makes him, let's see, how does he say it? It gives him the ability to concentrate on things and not be distracted. Infants may show an indifference or aversion to physical contact and a failure to respond to the voices and social invitations of parents. Oh no, I have an intellectual disability. Most also have some degree of intellectual disability, but the level of cognitive skills is uneven across abilities. About 1/4 of people with Fragile X syndrome meet the diagnostic criteria for autism spectrum disorder. Its presence is associated with lower development and generally poorer outcome. In the DSM 5 field trials, pooled reliability for autism spectrum disorder was very good at 0.69. Autism spectrum disorder is at least 4 times more common in males, although females are more likely to show intellectual disability. Prevalence rates have increased from 1 in 2,500 to 1 in 500 in the past 20 years. DSM-5 estimates the disorder frequency at nearly 1% of the population. Some may have particularly strong abilities in very narrow areas. Perhaps 10% of autistic individuals show savant syndrome or evidence of exceptional skills in mathematics, music, drawing, calculation of dates, mechanical aptitude, or memory. The great majority do not show savant syndrome. This is a drawing of a autistic child. Now the interesting thing is, look how wonderfully she drew the horse, but look how terribly she drew the human, because she's not used to looking in human faces. Pretty good job with the chicken. Autism spectrum disorder tends to run in families. About 5% of siblings of autistic persons also show the condition. Twin studies support a substantial genetic contribution. There have been positive linkage reports for every chromosome. At least 188 candidate sites are being investigated. DSM-5 reports that about 15% of cases are known to be associated with specific genetic mutations, with the remaining risk polygenetic and diffuse. Autism spectrum disorder shows higher serotonin levels than unaffected persons. Brain growth for infants have been reported to be accelerated in the first 2 years, followed by a slower than normal growth period. So the brain size is in the normal range by early adolescence. Abnormalities of the cerebellum and amygdala have also been reported in autism spectrum disorder. No consistent and unique abnormality is present. It is not possible to diagnose the disorder by means of any anatomical or biochemical marker. In other words, there's no blood test for it, and you can't take an x-ray to find out if there is an enlarged cerebellum or amygdala. It doesn't work. Several studies have examined the possibility that the increase in this disorder over the past 25 years could be due to the increased use of medical vaccinations, such as the measles, mumps, and rubella, the MMR vaccine. To date, studies have not found any evidence that vaccinations or mercury exposure is associated with autism spectrum disorder. When they looked at the level, the numbers of children, the percentage of children with autism spectrum disorder, and children that had been vaccinated and children that had not been vaccinated, the percentage was exactly the same. There's absolutely no proof that autism has anything at all to do with the measles, mumps, and rubella vaccine. Stimulant medications and newer antipsychotic drugs such as risperidone have been used, especially those with hyperactive symptoms, self-injury, and aggression. SSRIs have been prescribed to reduce repetitive or compulsive-like behaviors. The stimulant methylphenidate reduces symptoms of hyperactivity among autistic subjects. There is no consensus on the relative effectiveness and safety of any of these approaches. A variety of treatments for autism spectrum disorder have been promoted. Vitamins and minerals, special sugar-free or gluten-free diets, chelation therapy to remove heavy metals from the body. Chelation, I'm sorry, that's the way that's pronounced. Auditory integration therapy, craniosacral manipulation, secretin, sensory integration, facilitated communication, and holding therapy have been used. There is a paucity of research without substantial empirical support for any of these interventions. The reality is that sometimes they work and sometimes they don't. Sometimes they work for a while and then they stop working. There's no magic bullet. There seems to be no magic bullet. Attention deficit hyperactivity disorder has prominent symptoms of inattention, hyperactivity, impulsivity, or a combination of the two. At least some symptoms must have caused impairment before age 12. They must be present in at least 2 different settings, and they must interfere with academic, occupational, or social functioning. ADHD is the leading source of referrals for youth to mental health care. Attention deficit hyperactivity disorder is much more commonly diagnosed in males than females, approximately a 2-to-1 ratio. Most often, attention deficit hyperactivity disorder becomes apparent when a child enters school and is required to remain in a seat for periods of time. Prevalence of attention deficit hyperactivity disorder is estimated at about 5% of school-aged children. As children mature, the condition usually becomes less obvious and often attenuates significantly by late adolescence. Family and twin studies indicate a strong genetic component to ADHD, although strong family, school, and peer influences are also important in its occurrence. Reduced levels of activity in particular areas of the brain include the frontal lobe, the basal ganglia, and the cerebellum. They have been shown to occur with ADHD. DSM-5 reports that low birth weight may be associated with a threefold increase in risk. The specific cause or causes of ADHD remain unidentified. Stimulant medications such as methylphenidate, another name for Ritalin, have been shown to reduce the symptoms of ADHD in the short term and are effective for about 70% of the children compared to about 10% for a placebo. While useful in the short term, the medications do not appear to have long-term effectiveness and may stunt growth. A three-year follow-up of the multimodal treatment study of children with ADHD found that although medication produced greater improvements than behavior therapy at the conclusion of treatment, there were no group differences between medication, behavior therapy, or a combination of those on any measure 2 years later. There is no evidence that treatment with stimulant medication is associated with a reduction in later risk for substance abuse. The American Psychological Association's Task Force on Pharmacological, Psychosocial, and Combined Interventions for Childhood Disorders recommended that children should first receive a trial of psychosocial intervention and for ADHD before medication is initiated. The incidence of ADHD has increased dramatically over the past 3 decades. This may partially stem from practices intended to improve diagnostic reliability through the use of standardized rating scales. Although ADHD is observed in other countries, American children are more likely to receive the diagnosis. 80 to 90% of methylphenidate is prescribed for American children in spite of the lack of evidence of long-term effectiveness. The stimulant medications are not specific for ADHD, and drug response is not validation of the diagnosis. Normal men and boys respond similarly to stimulant drugs as ADHD boys. ADHD rating scales, which focus only on symptom presence, result in many false positives. There are no laboratory tests, neurological assessments, physical features, or attentional assessments that are diagnostic for ADHD. There are many non-ADHD causes for hyperactive behavior in children, including sleep disturbances, side effects of asthma medication, hearing impairment, child abuse, inadequate parenting, and onset of other conditions or difficulties. Disruptive impulse control and conduct disorders involve behavior that tends to bring the person into conflict with authority, often shown as impulsive or poorly controlled violations of social rules. Like the neurodevelopmental disorders, they are more common in males than females. Included in this section and double listed in the DSM-5 is antisocial personality disorder. Distinguishing features of oppositional defiant disorder are recurrent disobedience and hostility toward authority figures. Diagnostic criteria for oppositional defiant disorder includes often losing one's temper, blaming others for one's own mistakes or misbehavior, and being easily annoyed. The diagnosis requires the weekly presence of 4 such symptoms for a period of at least 6 months. If the person is under 5 years of age, symptoms are required nearly every day to qualify for the diagnosis. The severity of oppositional defiant disorder can be specified as mild symptoms in only 1 setting, moderate symptoms in 2 settings, or severe symptoms in 3 or more settings. Usually onset is before age 8, and it commonly precedes the development of conduct disorder. Strongly comorbid with ADHD and conduct disorder is oppositional defiant disorder. Some samples have reported incidence of oppositional defiant disorder as high as 11%, but they average about 3.3%. Before puberty, the disorder is more common in males, but after puberty, males and females show about equal rates. Training programs for parents or children with oppositional defiant disorder are among the most well established, empirically validated treatments. Conduct disorder involves repetitive and persistent violations of rules, social appropriate norms, and the rights of others, often taking the form of aggression, damage to property, deceitfulness, theft, and serious rule violations. The pattern is usually evident in a variety of settings over a 12-month period, and it must cause serious impairment in academic, occupational, or social functioning. Conduct disorder may be diagnosed in adults, but only in the absence of adult antisocial personality disorder. Prognosis is poor in childhood onset type of conduct disorder and in relation to the with limited prosocial emotions specifier. Commonly, conduct disorder co-occurs with ADHD and is also associated with mood disorders, anxiety disorders, learning disorders, and substance use disorders. Incidence appears to have increased in the past few decades and may be as high as 10% in the general population, although median estimates are closer to 4%. Conduct disorder tends to run in families and is more likely when parents or siblings have antisocial personality disorder, conduct disorder, substance use disorder, mood disorders, or ADHD. Other predisposing factors include parental rejection or neglect, use of harsh discipline, physical or sexual abuse, lack of supervision, peer rejection, below normal IQ, and early institutional living. Both genetic and environmental factors are involved in its development. Behavioral techniques have been effectively employed to treat antisocial and oppositional conduct in children and adolescents. It is key to train parents in behavior management skills and train both parents and children in problem solving approaches. Group based treatments may result in increased rather than decreased problem behavior by inadvertently reinforcing deviant values, increasing contact with peers who model inappropriate behaviors, normalizing skewed perceptions about the prevalence of delinquent activities. Intermittent explosive disorder involves recurrent outbursts of verbal or physical aggressiveness episodes involving failure to resist aggressive impulses. Intermittent explosive disorder may include destruction of property, physical attacks that injure others, or verbal threats of assault. The aggressive act, sometimes accompanied by strong emotions, is grossly out of proportion to any provocation or precipitating stress. These episodes are often very distressing to the individual. Diagnosis of intermittent explosive disorder cannot be given before age 6. Onset is usually in late childhood. Lifetime prevalence rate may be 7.3% of the population with average onset at age 14 and a lifetime average of 43 attacks. Most people with intermittent explosive disorder also have other disorders, which complicates the diagnostic process. Diagnosis requires the aggression not to be explained by the effects of a substance or general medical condition. The central feature of kleptomania is an irresistible urge to steal items are not needed either for personal use or for their value. For people with kleptomania, a growing sense of tension is experienced before stealing, replaced by pleasure and relief after the theft occurs. People with this disorder know that the theft is wrong, and they may fear being caught and arrested. They often feel guilty afterward. Stealing may be chronic and continue for years, despite a series of arrests and convictions. People who suffer from kleptomania have a high rate of hoarding, but individuals often report amnesia for the theft event. Comorbid conditions most often include major depressive disorder, anxiety and eating disorders, and other impulse control disorders. Kleptomania usually begins by adolescence. Prevalence in the general population for kleptomania is less than 1%. Three-fourths are female. I've known who suffered from three individuals who suffered from kleptomania. One was our discus thrower when I was in college. Geez, luckily he was wealthy. Well, he wasn't wealthy. His parents were wealthy, and they would reimburse whatever he took. Um, and he somehow stayed out of trouble. Another guy that had kleptomania was our shortstop when I played softball in Germany. Wow, that was interesting. He was really good looking, and that was probably one of the reasons why I never got into trouble. But he smiled and laughed about it, um, and people around him would pay for his things he stole. The third one was on a reservation. It was a lady. She'd steal coats, and the way she did it, she always wore an oversized coat, and she would take the jacket or whatever, and she would put it on underneath, and then just walk out of the store with a coat under her large coat. I She had so many coats. It was amazing, and she didn't steal women's coats. She stole men's coats. She stole all the coats. It was just so bizarre. Anyway, there have been some positive reports involving naltrexone, an opiate receptor blocker, for reducing urges to steal, but overall data is mixed. No pharmacological treatment is supported by controlled studies. Case reports suggest that covert sensitization and exposure and response prevention have been effective behavioral interventions, but no well controlled studies have been published. Carolyn Giuliani, Stephanie Pratt, Tia Tequila, Peaches Geldof, Rex Reed, Jennifer Capriati, Winona Ryder. These are people that have kleptomania, have been diagnosed with kleptomania. Farrah Fawcett had a problem. Britney Spears walks out of places with stuff. Lindsay Lohan. Pyromania involves multiple episodes of intentional fire setting, the urge to start a fire, and then there you go. A lot more women than men. Pyromania involves multiple episodes of intentional fire setting. The urge to start a fire is accompanied by increasing tension or arousal, and pleasure or relief accompanies the fire and its aftermath. Individuals are fascinated by fire and are attracted to and curious about all aspects of fire, including the paraphernalia, fire alarms, and firefighting. Although pyromania is an impulse control disorder, fires are not often set on impulse. The person is frequently indifferent to the possible loss of life or destruction of property that may result from their pyromania. Pyromania is more common among males with poor social skills or learning difficulties and associated with conduct disorder and ADHD in juveniles. It is common for fire setters to have a history of alcohol use disorder. Prevalence is unknown in the population, but 3.3% of fire setters in the criminal justice system may qualify for the diagnosis. Classic psychoanalytic theory considered pyromania to be a symbolic sexual act. Pyromania sometimes occurs in the context of fetishism. Others have proposed that pyromania is a form of communication, aggressive, or self destructiveness by juveniles with limited social skills. Suicidal thoughts or acts are very common. A few case studies have reported positive outcomes with behavioral interventions such as aversion therapy. Very little systematic work is available on the etiology or treatment of pyromania. And that is the end of that. I knew one individual with pyromania. Pyromania, he was in school with my sister. He was a year older than I was, and he was kind of a strange guy. One day he set a fire behind his house, and that was it. He was gone. They took him somewhere. Evidently, he had had problems before, but that was the last time we saw him. Okay, we're going to talk about chapter 16. I'm going to give you a quiz on chapter 13, but I'm not going to give you a quiz on chapter 16, mainly because we have so much to do anyway. So this is an interesting chapter, and the only reason I'm going through this is because there's some really good information in this chapter. Who treats mental disorders? There are a variety of professionals who have been trained in the assessment and treatment of psychological difficulties: psychiatrists, clinical psychologists, counseling psychologists, psychiatric nurse practitioners, and clinical social workers. Psychiatrists are medical doctors who have completed a specialization in psychiatry after earning the medical degree. Generally, 4 to 6 years of schooling beyond the bachelor's degree. Treatment typically involves the use of prescription medications. Sometimes psychiatrists may provide various types of psychotherapies. Clinical psychologists have completed doctoral training leading to either the PhD, Doctor of Philosophy, or PsyD, Doctor of Psychology degree. I have a PhD, Dr. Russ has a PhD, Dr. Barber has a PsyD, or PsyD. PsyD sounds kind of silly. Generally, 4 to 6 years of schooling beyond the bachelor's degree. That is the 4 to 6 years. Yeah, 2 years. Yeah, that's 2 years of for your master's degree, and 2 to 6 years for your PhD, depending on what the school is. If you go to the same school, a lot of times they will have a concentrated program where you get your master's degree. You stay in for 4 to 5 years and you get your master's degree and your PhD. After earning board certification or licensure to practice, qualified to independently diagnose and treat mental disorders. Although they do not currently prescribe medications, a movement in the direction is underway in the United States, and all depends on the state that you live in. Some psychologists hold a master's degree, generally 2 to 3 years of schooling beyond the bachelor's degree, and may become licensed as a psychological associate. These individuals treat mental disorders, but may be required to work under the supervision of a PhD or a PsyD. Counseling psychologists typically hold either a doctoral or master's degree in psychology and may have acquired the credential of licensed professional counselor or marriage and family therapist. Frequently, counseling psychologists provide assessment and counseling services to those with less severe disturbances such as marital problems and life or career difficulties. Psychiatric nurse practitioners completed training leading to the MSN, Master of Science in Nursing degree, generally 2 to 3 years of training beyond the bachelor's degree. After completing clinical rotation and passing nursing boards, psychiatric nurse practitioners qualified to diagnose and treat mental disorders and may prescribe medication under the periodic supervision of an MD. Nurses are really kind of interesting because once upon a time, a nursing degree was an RN. You went to school for 3 years and you got your nursing degree, but it wasn't a bachelor's degree. And then they started training nurses, and it was just nurse training. It wasn't anything else. It wasn't any of the gen eds and whatnot. And then they started giving nurses bachelor's degrees. So then all of a sudden, and this was in the 60s and 70s and 80s, all this was kicking up. You could either be an RN or you could get your BA in nursing. And of course, that included all the gen eds. And now things have really changed. The nurse practitioner had a master's degree and they were specialists. And they were a lot like doctors. They could diagnose. Things have just changed markedly since I first started in medicine back in the 1960s, 1970s. My mother was an RN, and at that time, that was as far as you could go. There were no PhD nurses, there were no master's nurses, and then things just expanded from there. Clinical social workers completed training leading to an MSW, Master of Social Work, usually 1 to 2 years of schooling beyond the bachelor's degree. Once they complete the requirements for supervised practice leading to the LCSW, the Licensed Clinical Social Worker credential, clinical social workers are qualified to provide therapy to those with mental disorders or less severe disturbances. One of the best counselors I ever came in contact with was up in Montana. She was an LCSW, licensed clinical social worker, and she that's not the right word. She serviced the whole north central middle of Montana. It was amazing. She had she had to travel all over the place. She was just an interesting person. Sometimes those with mental disorders find themselves involved in the legal system. Psychological and psychiatric evaluations are essential for providing critical information needed to render a judgment on commitment, competency, or insanity. The process of legal determination is less precise than that of clinical diagnosis, frequently requiring predictions of what might happen or estimates of the probability of dangerous behavior in future situations. Competency to stand trial concerns our individual's mental ability to handle his or her own legal affairs. In most jurisdictions, people charged with a crime are competent to stand trial if they meet all the following requirements. They understand the nature of the charges, they appreciate the seriousness of those charges and the possible results of a conviction. They're able to assist their attorney in their own defense. Defendants are assumed to be competent, barring arguments and evidence to the contrary. If the person is ruled to be incompetent to stand trial, the legal proceedings may be put on hold while the individual receives treatment or to restore their competency. The hope is that after a period of confinement and treatment for their mental disorder, such persons will regain their mental capacities and then be given a fair trial. This legal procedure has at times led to long-term confinement without the safeguards of a trial. The rights of individuals to be protected from the unreasonable detentions based on incompetency to stand trial have been bolstered. In Jackson versus Indiana in 1972, the Supreme Court ruled the length of pretrial confinement should be limited. And usually the judge will say, we're going to confine you, and after a certain amount of time, you will be released. Assessing competency is not an easy task. Such clients are motivated to exaggerate symptoms or malinger. In one review of 105 criminal defendants referred for neuropsychological evaluation, the rate of probable and definite malingering neurocognitive dysfunction was over 50%. Not uncommonly, the expert opinions of prosecution evaluators are very different from that of expert opinions of defense evaluators. A disturbed individual may be incompetent to make treatment choices or to conduct daily affairs, including financial and legal decisions. A treatment guardian, for example, is often appointed when a person with a mental disorder is too disturbed to make informed decisions about accepting or rejecting proposed treatment plans. The matter of sanity is a different legal issue from that of competency. Sanity has to do with the person's mental state at the time of the crime, not the trial. The concept is connected to the notion of responsibility over one's actions and, as a result, over guilt or innocence. Competency and sanity, therefore, involve independent judgments of mental status at different points in time. At the very core of the rule of law is the assumption that individuals bear responsibility for their actions. There is a long tradition in English law that if persons are so mentally deranged that they have no comprehension of the meaning of their criminal act, they are not legally responsible. The MacNaughton Rule, which was established in England in 1843, is a rule of knowing right from wrong. Irresistible impulse rule, which was established in Alabama in 1887, is a pathological drive or impulse that the individual could not control had compelled the crime. The Durham Rule, which was established in 1959 in the United States, an accused person is not criminally responsible if it is shown that the unlawful act was the product of a mental disease or defect. This rule proved to be very difficult to apply effectively. The American Law Institute issued a more comprehensive standard in 1962 in its Model Penal Code. The ALI standard stated a person is not responsible for criminal conduct if at the time of such conduct, as a result of mental disease or defect, he lacks the substantial capacity either to appreciate the criminality, the wrongfulness of his conduct, or to confirm his conduct to the requirements of the law. As used in this article, the terms mental disease or defect do not include an abnormality manifested only by repeated criminal or otherwise antisocial conduct. The Federal Insanity Defense Reform Act, passed by the U.S. Congress in 1984, described the insanity standard for all federal courts. The ALI limited the volitional, competent, or conforming conduct to the law and partiality returned to the MacNaughton standard. A person charged with a criminal. Wait a minute. Let me see what's going on. Let's stop right here. That's enough. We can get into this. This is Dr. Barber's area of expertise anyway. So let's go ahead and turn this thing off. That's enough.